Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the podcast. This is Aebhric O'Kelly. This week, we are again with Dr. Ella Corrick, who runs our postgraduate faculty and our Doctor of Health Studies. Ella, welcome back to the program.
Hi, Aebhric. Thanks for having me.
So tell us a bit about yourself and what is keeping you busy.
So I am a physician in the North Highlands of Scotland in quite a rural area. I work in family and emergency medicine, but I had my baby girl, my daughter, 9 weeks ago. So that's keeping me very busy. She's keeping me on my toes. So she's really taking up a lot of my energy and time, but I'm enjoying having my sort of lacuna, my islands of work time to keep in touch with medicine and the other parts of my brain.
Nice. So is that reducing your call out for the mountain rescue?
Yeah, so I've handed over my mountain rescue medical officer responsibilities to a friend for 3 months. So she's handling everything, and I'll be back in the saddle in a few weeks. But at the moment, I'm just kind of dipping in and out, as all things in modern life. There's a million WhatsApp groups associated with the mountain rescue team. So I periodically check in on the WhatsApp groups and keep in touch with what's happening, but keeping my hands off the responsibilities for a few more weeks. Yeah, it's working well.
Ella, you took over the DHS program a couple of years ago. You joined the CoROM faculty. And to be fair, we are so much better because of you being part of the team. But what attracted you to take the DHS program from CoROM?
Well, thank you for that. What attracted me, I guess, because my practice clinically is in a very rural setting, and I've always been really drawn to rural settings, and particularly island medicine. My family medicine practice is in the Outer Hebrides in one of the Scottish Highlands, and that's where a lot of the faculty and students at CoROM come from. So just having that commonality of purpose and it being a place where people understand those challenges, and it brings together people who work in different settings or, very different countries, but similar types of settings. So we have these shared problems in very different places. And I really enjoy the environment. I think really what brought me in was the people. And I think that's true for a lot of people in CoROM, where, I got to know you, Aebhric, I got to know John, who's our dean, and Chubba, who runs our master's program. And you're people I enjoy talking to, and I like the work that you do. And so that's kind of drew me in.
I recently learned that you and I met in 2012 or 2013 on a PHTLS course in Ross-on-Wye in the UK.
Yes, it would have been 2013. That was the year I graduated as a doctor. I was working as a doctor in the Channel Islands and went to a PHTLS course, which you were running. I remember it really well, but I guess the instructors are a little bit more memorable to the students. Yeah, so I remembered you immediately. And Tom, who's my husband, who works on the BSc, he knew you a little bit more and brought us into the college, I think, initially. And I remembered you well from that PHTLS course.
I'm terribly sorry, but I don't remember that at all. And I apologize, Ella, for that. But you understand hundreds of people have come through. But
exactly,
that's fantastic. So and now you are running the doctoral program as well as you're head of our postgraduate faculty. But we focus on those that work in remote, austere, resource-limited environments. And many of our students are experienced clinicians, but with little or no research. How do we turn that operational experience from the remote clinic, from the ship's doctor, ship's paramedic, from expeditions and conflict zones? How do we convert that knowledge, that drive, that passion of our students into high-quality doctoral research that we can genuinely influence austere medicine?
Well, I think most people working in those settings, they're incredibly motivated to do a good job for the people they're serving. They're either working in a really small community where it's their friends and family that they're treating, or if it's more of a kind of offshore setting, these are people they work with day in, day out, and they know they need to keep them well. And I think most people working in these austere settings have a real sense of responsibility to their patients and wanting to do the best for them. And I think we all know that to improve things, we have to understand a systematic way of improving things. We need to keep up to date with research. And really, that's what research is about, improvement and seeking the best for our patients. So I think people who enter the doctorate come in really motivated, and they're coming because they want skills, either to conduct their own research because they see a gap in the knowledge in the place where they're working. That's really common. There's so little research in some austere environments. Or they come in knowing they want to make a difference. They want to keep up to date and be really on top of their research. And to be really good at understanding research, I think you have to have conducted some research, because then you understand what authors are saying when you read their conclusions, their methodology. Sometimes you can read between the lines when you've done that work yourself. And so I think people come in being driven by their own passion, either wanting to be better at handling research, or there's research they want to conduct because they know it needs to be done in the place where they work.
So you have been doing this for a couple of years now, and you've seen quite a few students come in. Tell us about the CoROM doctoral student. Who are they? What brings them into your DHS program? What is their passion?
We've got a really good mixture of backgrounds in our current students. So we've got physiotherapists, nurses, paramedics, offshore medics. And so we've got a really nice range of professional backgrounds. But I think the thing that they all share is they work in resource limited or very rural settings, and they work in a place where there's a lack of research going on already, or if the research is happening, it's maybe being directed by people who are in urban settings and don't fully understand the rural or the resource limited setting. What kind of research they're doing, again, is really varied. So we've got students who are interested in security of healthcare provision in military or conflict settings, versus students who want to investigate the impact of closure of rural community hospitals, and everything in between. Students wanting to look at mass casualty triage. We've got people working on systems improvement in humanitarian settings. So we've got a really interesting range, and our faculty come from a similarly diverse background. We have faculty who have particular interest in conflict zone and disaster medicine, and then people like myself. So my interest would be more in kind of mountain rescue settings and rural medicine. And then we've got others who are interested in global health engagement or telemedicine. And of course, Chubba, who runs our Masters in Austere Critical Care, has a research focus in resource limited critical care.
So looking at the future, what type of doctoral research would you like to see coming from the college? What direction do you want this to go, or what niche do you see us getting into?
Well, so all of our faculty have our research interests that we're kind of conducting already. So I just mentioned some of those. We would love students to come in who have interest in those areas: mountain rescue, prolonged casualty care, global health engagement, telemedicine in rural healthcare, or resource limited critical care. Those are all areas that we have faculty actively working on. And many of those, we already have projects going on as faculty that then students would be able to sort of take on and make their own. On the other hand, I love having students come in who have an existing interest. I think if people come in with passion for something, then they motivate themselves. And really, to achieve a doctorate and to get your thesis done, you really do have to care about what you're working on. And it is a long marathon of a degree. And to get that thesis completed, you have to knuckle down and be self-motivated. I can pester students, I can email them and check in with students, but at the end of the day, a doctoral program is all about achieving independent research. And so people have to come in self-motivated and interested in what they're going to do. And whatever that interest is, if it's within that wheelhouse that CoROM has interest in, austere and resource limited medicine, then you're going to find faculty who will also catch the passion for that project. And really, I find, I don't know if you have this as well, Aebhric, if someone talks to you about something they're passionate in, it instantly becomes interesting because people can convey that passion and convey why it matters to them. And so if a student comes in with a particular interest, then I think we can make that work for them. The only limitations I would say is we're not set up for lab-based projects because we're an online doctorate. So people who want to do a lab-based project, we probably wouldn't be able to support. But other than that, we'd welcome students with open arms.
I understand the lab component. We're not doing STEM research. This is mainly big picture thinking. So having a lab doctoral program is not really what we're aiming for, is it?
No, exactly. We're not going to have students sitting in a lab for 10 hours supporting their cell cultures for good or for ill, but we can support anything where either it's, as you say, kind of big picture research, or if people have already got access to research data through their work setting or anything like that, then as long as they're able to ensure robust, safe management of data, and as long as they have ethical access to that data and approval to use the data for research, then we're happy to support that. And we do have cases of exactly that in our current students. Equally, some of the faculty have access to data that are rich sources for research. So in the areas that I've mentioned, if students don't have any access but want to study those areas, then faculty would be able to support them. And so it's not that we're only doing research that you can do sitting at home. Some of our students are going out doing research in hospitals, and we can support that, but it just needs to be in a way that we can manage safely and supervise safely.
So for the listener who doesn't know much about our DHS, our doctoral program, can you tell us a bit about it? What's the cost? What are the requirements to enroll, and what will the student experience?
Yeah, sure. So the doctoral program, the DHS, it's a professional doctorate or a taught doctorate. So that means that it is ultimately you are a doctor at the end of the program, but there are components, there are modules that are taught, whereas on a traditional PhD program, depending on which university you're with, some of those have no teaching at all. So you join, you have a supervisor, but from day one, you're just doing your research, you get your thesis done, and you leave. With the professional, the taught doctorate, you have some taught modules, which I think lends itself really well to a couple of different types of students. So if you've had a long gap away from study, from education, then the taught modules kind of give you an on-ramp before you're expected to dive into the research on your own. They are also very good if your previous degree, so most students who join us have a master's, but if your master's wasn't particularly research heavy, then our taught modules will give you the skills and the tools so that you're not feeling like a total beginner when you dive into your own research. Or if you're someone who values structure, a PhD can feel incredibly unstructured. And I think most of us who work in academia know people who have spent 7, 9, 12 years getting their PhD because it's not a directed journey and people can go on really incredible journeys, maybe an incredible experience, but, really go off on tangents or lose themselves in the weeds and take a huge amount of time to get their focused research done when actually you could get a PhD done within 3 years, if you have a straight line through it. Our doctorate gives you a bit more structure. So hopefully fewer of our students end up going off on tangents and getting lost in the weeds. The structure of it is that the taught modules run for the first 2 years, and our modules run things like systems improvement, medical ethics, leadership, academic writing, and research methodology. And through those, the early ones are getting students stuck into the structure of our online study, being students again, doing some writing, thinking about how things work and how we improve things in medicine. And then we segue into the modules that directly address aspects of your thesis. So by second year, the modules that you're doing hopefully result in writing that ends up in your thesis. So it's not wasted time. It's all building into your thesis. The second year modules are research methods and academic writing. And our intent is that by the end of that second year, all students have written their research protocol and have got their literature review done. And then you enter third year, and that's the time when it does become open play and you're just doing your research supported by your supervisors.
We've had a few graduates now. How long have they taken to get through the program?
That's a good question. So we've got one graduate so far, and we've got two approaching graduation. And our graduate took 5 years, I think, but that was with a short hiatus in the middle. The full-time quickest that you can complete the doctorate is 3 years, and most of our students enter as full-time, even though they do have other responsibilities. Because of it being online, it has that flexibility to support people, especially we understand that students who, for example, work offshore might be working 3 weeks on, 3 weeks off, and either only work when they're offshore or only work when they're onshore. So we can accommodate that flexibly. So we do have lots of students who are full-time and aiming to complete in 3 to 4 years. I would expect most students to take 4 years, because once you hit that research stage, although students come in with a really good idea of what they want to do, I think usually you find that you need to make changes. Your research doesn't work exactly how you expect it to. So getting the research done usually takes longer than people expect. But actually, it's that writing up stage. Some people are incredibly self-disciplined and can get their thesis written quickly and effectively. But most people find that writing up stage drags a little bit. And I think that's what slows most people down. My PhD took me 5 years, and I was working full-time for 3 of those years.
You did your undergraduate in Oxford, and then you did your PhD from Nottingham.
Yeah, that's right.
What was your thesis?
Yeah, so at Oxford, I did an intercalated, what's called a BA, because Oxford doesn't do BScs, but it was scientific, in which I did a dissertation. And that was on, completely unrelated to my subsequent research interests, was on the evolution of the knee through different species, looking at how you can see this particular angle in the knee joint change in different species, including ancient humans and Australopithecus and things. So that was cool. And
That's fantastic.
I have a very fond memory of piling a hospital bed with different skeletons that we were loaned from a museum in Oxford onto this hospital bed in the middle of the night, because the MRI machine was free in the middle of the night, and we got permission to MRI all of these samples
Nice.
overnight, wheeling this hospital bed stacked with skeletons through the hospital corridors in the middle of the night. And it was great. So that was my undergraduate research. And then my PhD was in how we can measure quality of prescribing for children. So there's different tools, especially in older adults, for rational prescribing, and there aren't really any for pediatrics. And when I started my PhD, a French research group had just published a tool for pediatrics, but it had some significant flaws. And, I guess it's a first iteration of something. There's always going to be room for improvement. And it was also, sorry, you might be able to hear my daughter crying in the background.
That's brilliant. Absolutely brilliant.
I think my husband is doing his best. She might need me.
No bother at all. You just give her a microphone, it'll be grand.
And so I was adjusting it, because it was also, that tool was very much designed for the French settings. So there were medications there that aren't licensed in the UK, for example. So I modified that research tool for a UK setting, and then did a validation study with it, inter-rater reliability, and then also a clinical validation study, which was a really, really great project as a doctoral student, because it had so many different parts to it. And so it introduced me to a really good variety of different skills in a research setting. I'm really glad I had that clinical component, so that I got to do the actual real life consenting of families and recruitment, and how you handle all of the data for recruitment, all of this stuff. When you read a study, it's 2 lines in a research protocol. But when you do it in real life, that is months of your life that you spend doing it. And so I think the real life exposure to those things makes you better at reading studies. It makes you pick up when studies are maybe fudging what they did. You can tell when they claim they did something and you say, I'm not sure that's possible. I suspect maybe you didn't do it exactly how you're writing it. And then it also really helps when you're obviously supporting students to do research. Students maybe come in and say, I'm going to do 2 weeks of data collection, and you can caution them that it might take a bit longer than 2 weeks. So that mix of projects for my PhD was really helpful. And then postgraduate, the kind of work I've been doing, I've had a lot of time obviously in clinical practice, and so my research time isn't as freely available as I would like, but I've had some publications, mostly in education. So I've written chapters for textbooks and so on. But the thing I'm excited about is that I'm hopefully shortly going to be starting a really big study into the UK Coast Guard. So we're just in the starting phases of that, and that should be really interesting.
That's fantastic. Doing research on the Coast Guard sounds very interesting. But you got your PhD in pediatric pharmacology. Oof.
Yeah. So technically it was pediatric pharmacology, but in practice it was really about how do we evaluate quality of prescribing, and how do we test something that's so nebulous and try to quantify it or try to systematize it in a way that we can actually evaluate it objectively. And of course, there isn't a simple way to objectively evaluate quality of prescribing, because as a clinician, it needs to be individual to each patient. But if you're trying to do an objective quantitative study of that, the data are so nebulous. Who's to say that prescribing this child a tablet versus this child a liquid medication is better or worse? It depends whether the child's capable of swallowing tablets, right? The tablet might be cheaper. So on a system level, we might prefer that everyone got tablets as soon as they can. Equally, there might be a patient preference for they would rather put up with symptoms and not have medication as often. Or they might prefer to have the more expensive medication if they only have to take it twice a day. Those things can't very easily be captured by a measurement tool, but what can be captured by a measurement tool is a proxy for good quality prescribing. So if you identify things that are almost always going to be suboptimal or perhaps going to be errors, and you measure those, then you can compare between different systems and say, well, this type of suboptimal prescribing is happening much more often in this setting than this setting, or this group of prescribers versus this group of prescribers. And so that proxy measurement, even though it doesn't capture the nuance and what perhaps I'm most interested in, and definitely what I'm more interested in as a clinician, my patient's best interest in that individual consultation, that's very difficult to capture. But what we can capture for a research purpose is a proxy. And that's true of so many different types of research, and is a useful sort of concept for any clinician to get their head around, because then when you're going and reading research that affects your area of practice, you have to understand that often what's being measured is a proxy for what we're really interested in. And that comes back to what I was saying at the beginning, that studying for a doctorate gives you these skills that you don't only take forward to do future research. And I hope many of our students, they're entering as early careers researchers and are going to go on and do further research in areas that really need researchers. But even if people don't intend to carry on being researchers and they want to primarily be clinicians, I think what you gain from your doctorate, and a lot of people with PhDs or other doctorates will say the same, it's not the thesis and it's not that individual research project that you did that's the biggest win. It's the skills that you had to learn in order to complete that research. And you take that into every paper that you read going forward.
So doing a doctorate is going to make you a better researcher.
It's going to make you a better researcher, but hopefully it's also going to make you better at reading research and applying research to your practice. Because I think the ease of access we have to research, you can go onto Google Scholar or you can use an AI search, although my reservations about that. You can read research, and that's awesome. We have so much at our fingertips thanks to the internet. But there's a real danger of people with a level of naivety reading a single research paper that has a great p-value and a huge, significant difference found in their study, and then immediately applying that to their clinical practice. And if that's a single study of a single group that is conducted, well, however robust the methodology was, in most cases, a single study shouldn't be changing our practice. There are exceptions, but in most cases, one clinical study doesn't mean that we should all be immediately applying it in our clinical practice. And so I think clinicians who want to keep up to date with research, who want to be, improving their own practice and not just waiting for massive society guidelines to come out, or they want to understand the basis of those guidelines. Most guidelines publish what their research basis is. And sometimes you can dive in and read that research and realize, oh, actually, this recommendation is based on really weak evidence, but this recommendation is absolutely clear and we 100% should be doing this. And so you can then take those into your practice with a deeper understanding of why you're doing them and be less liable to being misled by either badly conducted research or really well-conducted research that's still too early and still too small for it to be safe for us to incorporate into our practice.
Is that one of the differences between a DHS and a PhD? The DHS is really aimed at clinicians.
Yeah, I would say the DHS is aimed at people who are still practicing and who are probably going to continue practicing. Not necessarily. You could do a DHS and then be an academic for the rest of your life and just do research. But I think our program presumes that you're going to remain a practicing clinician and is probably designed for those people. Certainly, most of our modules ask students to draw on their own experiences as clinicians or in their workplace setting to problem solve or to identify. For example, we have this systems and quality improvement module. And so most of our students draw on their real life experience during that module. So if we had a student who came in who wasn't a practicing clinician, I don't think it would be a problem. But most of our students are, they're still wanting to practice and they're doing this because they want to improve what's happening in their workplace.
So Ella, tell the listeners what they should consider if they are joining our doctoral program.
Great question, because I think everyone comes in with a reasonable idea of how they think they study, but I think students should come in and have a really good idea of what time you want to set aside for your studies versus your practice. And as I say, all of our students at the moment are working clinically alongside their studies, or in one case working in research, but everyone has a job and we don't expect our students to be full-time students. But you do need to have figured out how you're going to have that work-life balance. And I think coming in and having an unrealistic idea that, I'm going to study every day while I'm at work because work can be chill and then it'll all be fine, and then getting yourself really, really stressed and trying to study all the time is actually more harmful than if you say to yourself, actually, I'm going to have, this one day a week is my pure study day, and the other days I'll just keep in touch with it. Making sure that you're not expecting too much of yourself alongside your day-to-day work is probably really important. And if you need to drop to part-time, then that is always an option for our students. So I think most students join full-time and I would support that. But bearing in mind that if they're struggling with the workload, they can drop to part-time and have longer to get through the modules. The other thing I think is have a broad idea of what area of research you're interested in, but don't commit yourself to one project. I think there's a danger sometimes when people come in with a pet project that they realize partway through their studies that what they imagined their research would be won't actually work, but they've already in their heart committed to that project. And it's a real wrench it feels like you're killing your baby. That's a term from fiction writers when they've got a part of their plot that they love and they realize it just doesn't work and they have to kill their baby. And so I think come in with an idea of what you want to research. That's great. And even if you know exactly what you think you want to study, come in with a little bit more open-minded and be open to allowing yourself the adventure of discovery, because you might find there's a much more interesting or effective way of tackling the problem, and just be open to that possibility. Equally, if you have no idea what you want to study, that's great, because we have faculty who have research interests that they would love a student to catch a passion for. So if you come in and you just say, look, I love austere medicine and I want to do research and I want to learn how to do research, but I don't have a pet project, that's great. Tell us that at interview, and over the course of your first year, we'll find an area that suits you and pair you up with supervisors that can support you.
Each of us at the college have our primary research interests. What is yours?
Well, at the moment, I would say this has gradually changed over the course of my career, as my undergraduate and my PhD show. At the moment, I would say I'm interested in two things. So I'm interested in how mountain rescue and hospital volunteer services train their responders, and what resources they need and what resources they actually use. There's always a mismatch between those two things, and there's a mismatch between training and practice that I'm interested in. And I'm also really interested in the area that I practice in, so in really rural primary and emergency clinical practice, and how we provide services to small communities, both in a systems sense. So how economically can we ensure that rural communities get equitable healthcare? And then also more on a clinical sense of how do we maintain training? How do we sort of reconcile the fact that as a very rural practitioner, I am going to be the only person there when somebody comes in needing a surgical airway or somebody comes in needing a chest drain. But compared to a clinician in an urban setting, I'm going to do those so much less often. And in some settings, and certainly in the UK, in lots of different procedures, there's the idea of you need to do X number per year to be considered competent. How do we do that for rural clinicians who can't just leave their rural setting and go work in an urban centre every month or, a couple of times a year? How do we maintain skills and make sure the service we're providing to rural patients is safe and effective? So that's something that really interests me. And I think there's a lot more similarity between those two things, the kind of mountain rescue setting and the rural hospital setting, than people might realize, because they're similar challenges. It's just that the clinicians have very different levels of exposure. Some of our mountain rescue responders, they have completely normal office jobs when they're not out on the hill. And that's a really interesting training challenge. There's so much I could go on. How do you prepare somebody who has a normal office job for the types of trauma they might be exposed to in mountain rescue medicine? What's the best way of doing that? I don't think we have any research that tells us what's the best way of protecting people's resilience. And a lot of resilience teaching and practice is based on vibes, what people think sounds like a good idea or seems like a kind thing to do. We don't necessarily know if that's protective. You and I both know that most medical communities tend to have a really black sense of humour. And I personally think that dark humour and the camaraderie between clinicians is really protective for us. And that usually develops, I think, organically in clinical settings. Is that helpful? I think so, but I don't know what the research says. What do we do in these volunteer settings where maybe people aren't coming from a background that indoctrinates them into the dark medical sense of humour? What should we do? I don't think we know.
That's a valid question. I'm reminded of my time on a volunteer fire department in Fayetteville, North Carolina, where we could be sitting in an office and then 25 minutes later in an inferno trying to save someone from, and the same as a deputy sheriff. We had reservists whose job was anything, a cleaner, it doesn't matter, but then they go through the academy and then they will do a shift as a cop. And how do you, that's a profound change, isn't it?
Yeah, exactly. And then you sort of magnify the impact when you're doing that in a really, really rural community where maybe the inferno is at your uncle's house and everyone knows everyone. And you don't have the, I think, probably protective distance of urban practice where something terrible happens. But, the first rule of the house of God, the patient has a problem. It's not your problem. But actually, when you live in that community and you see the impact ripple out through the community and you see the bereaved relatives when you go to buy your groceries, that's a very different impact. And I think can be really hazardous to the well-being of practitioners. But then there's elements that can be protective. You also see the good that you do, and you have folk who recognize you and thank you. And maybe there's that element of it being more of a calling rather than just being a job. And I think that can be protective and beneficial. So there's interesting challenges.
Ella, I'd like to ask you a personal question. What are you currently reading?
Well, I just recently finished reading a book by Claire North called Touch, which I would recommend very highly. It's I guess it's sci-fi in the sense that the central premise is something that can't happen. So a person who can jump bodies by touching, and then they'll jump into the other body.
Wow.
And therefore they can be effectively immortal because they can jump from a dying body into a new body. But it's written like literary fiction. So whereas I think a lot of sci-fi is written in a more kind of conversational or colloquial way, it's really beautifully written. It's not purple prose. It's not overdone. It's just right. It's fantastic, and it reads like a thriller. Absolute page turner. I couldn't recommend it more. And so next on my list is another Claire North, because she's definitely won me over.
So now I'm curious. Do they do evil with this, or do they do good?
Well, that is the problem. You can do either, and there are different entities, some of which don't do such good, and the resulting is very exciting. I don't want to even give anything away. I went in knowing nothing, and I think that worked really well. I just started, and it starts with a bang, and I think that worked really well for me, not knowing what I was going into.
Nice. In the past, you and I had touched about the Expanse universe. How was that for you?
Oh, that was great. So I still haven't finished it though. I think I'm 5 books in. The problem with the Expanse is, as with lots of good series, everything goes so horribly wrong. Sometimes I just need a break from those characters having such a terrible time. I want everything to come up for them, because you fall in love with the characters, and you really do fall in love with them. And the cruel author just makes terrible things happen to them.
Yeah, prepare yourself for book 6. That was rough. Fair enough. So, Dr. Ella Corrick, my final question for you is this. What advice do you have for the new doctor, the new nurse, the new paramedic who is just starting out in their career in austere medicine?
My advice to them would be to stay curious, and wherever you're working now has its one way of doing something, but maybe that isn't the only or the best way to do that. So just stay interested and be open-minded. And when you come across someone who does it a different way, don't immediately think, well, they do it the wrong way. There's going to be a reason why they do it, and it might be a bad reason, right? It might be laziness. It might be that they've just got stuck in an old way, and that might be bad, or there might be a really good reason for it. So stay curious. And if that leads you to research, read the research. Don't automatically start doing something just because one study said it was a good thing to do, but stay curious, stay interested, and just be aware that the way we're doing things right now might not be the best way, but maybe it is, maybe it isn't. Keep your mind and your eyes open.
That's fantastic advice. And it was really great to have you back on the podcast. I imagine we'll see you again, but thank you for what you do for the college and for the path that you walk in this life.
Thanks for your interest and your curiosity, Aebhric.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.